again, I think this is going to be a broad response here. What is the best way to document a high-risk refusal?
Lots of documentation.
Lots of it. I mean, that's the condensed version, right?
No, but I mean, we have in our hospital system, we have very particular protocols about such a thing, and you're making sure that you get vitals, mental statuses, histories. If you go all the way to talking to a physician based on the vitals, if the vitals are not meeting criteria, you have to talk to a physician. So, I mean, documentation is your friend there. Document everything.
Yeah, I think, too, does the patient have capacity, right?
That's
So
a big word, too, capacity.
Does the patient have capacity? Have we done a good assessment? Do we have all the vitals? Easy one thing is, 100-100 rule. Do I have a heart rate over 100? Do I have a blood pressure less than 100? Do they have fever?
Right.
What's their blood sugar? And then online medical direction, which I think we're seeing a huge shift in that. I know I could speak for our organization. It seems like we've had a couple high-risk refusals lately where our guys are a lot more eager to call, and we're putting the physician on the phone with the patient, explaining, this is why. Like, we had a scene time of, over 45 minutes the other day, and it was all because the crews really tried for, 20 or 30 minutes, and then they called and put the patient on the phone with the physician.
Good for them for doing so.
And they did a good job. Ultimately, it ended up in a transport, which was good. That patient needed to go. They were in AFib with RVR at 150.
Well, and sometimes, and it happens in pre-hospital space and ED, where sometimes I get a nurse like, oh, this patient's really upset and they want to talk to you. I'm like, okay, and I go in there and they're as nice as can be, but it's because of my initials after my name and not for any other reason.
Or they'll give you an entirely different story than what they give us because of the initials, and that's fine.
That works both ways.
That's not even because of the initials. I mean, whether I was a student, I got a different story than the resident got a different story than the attending. We know that happens. But sometimes it does change the perspective. Like, oh, I've got a doctor on the phone that's telling me I should do this. That sometimes is enough to push them over the edge, and that's for their benefit, right? I don't know what's going on. Although, hey, you're in a deadly dysrhythmia. You need to come to the emergency department. We're going to keep you here in the hospital. We're going to make you feel better.
Yeah.
On top of all that,
I got a great story for you that this will all make sense. Not that long ago, and I won't use any names. One of my medic students had issues abdominally. And I gave a lot of reassurance. I said, it's probably this. It's like, I should probably go to the hospital. I should probably do this and that. I said, you know what? Let me call Dr. Hill. And I put him on the phone with the student, and, 10 minutes later, the student was fine. It's like, I'm going to work this out. I'm going to do this and this and this. And it's like, and it wasn't so much that there wasn't trust in me, but exactly your point. She got to talk to a physician, and everything got settled down. We're good. So
the other point I have with that with documentation is a lot of our EPCRs, I can speak to our organizations specifically, there are baked in things as soon as you hit patient refused. Then now it opens up, on our end, in our facility, or in our organization, it is going to force a capacity assessment.
Yeah, right.
It's going to force certain items. It asks, did you contact medical command? Yes or no. If you did, it wants the physician's name, et cetera. So, we forced a lot of those things in there to protect ourselves, but ideally, you also have to write a good narrative. You have to tell a good story, because if you leave and 20 minutes later it's a full arrest, and the neighbor's like, well, the ambulance was just there.
Yep.
What the hell didn't they do? You have to have something documented.
Well, and it's not going to be that person that's going to be the one
family.
It's going to be the family that's going to be upset with you.
Sure.
You didn't
and I lived that scenario. Years ago, I had a patient that I came in for a recall. We went on another call. It was a sign-off, and we really wanted this patient to go to the hospital. Now, our protocols weren't the same then. This was several years ago. But we signed the patient off ultimately after I put in my narrative that I think you need to go to the hospital. If not, this could cause even death. Mm-hmm. You need to be seen by a physician. 45 minutes later, the squad was back there working an arrest.
Yep.
And, the family was pretty upset about that. And I get it. And they wanted, ultimately the reports got subpoenaed, and everybody agreed with everything that was written. It was like, they tried, but you still have rights. We can't kidnap you.
Correct. Yep. I think documenting that they don't want to, they're signing off against medical advice. Mm-hmm. The conversations you have with them, what your risks are to them, it should always include death, disability, whatever specifics is going on with them. Tell them that you're welcome to come back. They can call you back at any time.
That's a big one, yep.
Yes.
You should also ask them, why do you not want to do this? And then put that in your report. So that way it'll show whoever's reading it that, they did do this, and they can even show why the patient didn't want to go.
Or even further, they showing and proving that they had capacity, which is
correct. Or it might be, I don't know what to do with my dog. Well,
We'll figure that out.
We'll figure it out.
Then I can fix the dog. If I get your dog taken care of, does that mean you'll go, oh, yeah, okay.
Not pushing for this, but we've literally taken dogs to the ED with our patients, waiting for some everybody else.
We love that, but I understand.
But then all the staff wants to surround and pet the dog, and maybe it's a good dog, but we don't push that, but it has happened. Yeah. I mean, we will make any exception to try to get you the help you need. We're patient advocates.
My little psychology trick is I say, when you change your mind, you can call us back. You know, setting the stage, of course, that I expect you to change your mind. Right?
But absolutely, I've put patients on the phone with doctors before, and it's worked or it hasn't.
Yep.
But at least I have that even on. It's all recorded.
It's recorded. You have that additional layer of liability reduction.
I've used the police a couple times as well on high risk refusals because they wear body cams. So, and I've been very forward to be like, okay, this officer's going to stand here. I actually did this. I told you about this one. It was great. It was OSP. I was like, could you please stand here for my whole conversation? Yeah, why? I was like, because you're wearing that.
Because you're
Is
wearing
it on?
that.
And he's like, yep. I'm like, perfect. I need you to listen to me. And I go through my whole thing, call the hospital, put the patient on, has capacity. Doctor's like, yeah, you should go. Your physician's like, you should go. He's like, no, I'm not doing it. I'm like, perfect, thanks.
Yeah.
And I actually wrote that in my report. I got the OSP officer's badge number. I wrote, this OSP officer was present for all of this. His body cam footage was on. Like, so not only had the recorded phone call, if they really wanted to, we could subpoena his body cam footage.
Do you foresee ever time in the future that we're going to be wearing body cams? I just feel like this is so HIPAA intertwined that it's above me.
Somebody smarter than me is going to argue that there is some HIPAA, but it's as long as it's treated appropriately. We're already recorded audio. We're recorded video coming and going to and from the ambulance, out in the ambulance.
To me, if it's kept the same way and kept under the same perimeters of a patient care report, why is it any different?
If it's treated as such, then no, I personally don't believe there's a problem. And then secondarily, I personally welcome it. I mean,
I do too.
I would too. I mean,
there was actually somebody doing a research project on that very topic of EMS wearing body cam.
I would love to see the outcome of the research because
I
would push it.
No.
Oh.
No, sorry.
Like you said, I would love that. I know some of my squad mates would
lose it.
Oh
No, I think we all know a battery of people that would be vehemently against body cam. I've got nothing to hide.
So I make the joke when we're doing run reviews and I pull up the telemetry data from the monitor and I say, you guys know that this records everything, right?
A lot of times they don't know that, though.
Well, that's an education.
Well, you forget.
Yeah.
Everybody forgets they're being recorded.
Yeah.
But then I joke, like, it also audio records, so I should pull that up. And you see, like, the faces, like, what are you talking about? Like, I'm joking. At the same time, I think it would be totally reasonable to have your monitor actually do audio recording, to actually understand what actually happened on scene. I don't necessarily need video. Audio is going to be a huge piece of information. And when we're talking about things of care that's provided, I don't want to just go based upon subjective data. Reports are great, but objective data of an audio recording or a video recording
rules the day.
This is how these people remember it, and this is how they wrote the report. This is the video or audio recording that backs up everything else that's also happening.
I agree with you, Scott. I would welcome it. I have nothing to hide, like you say. Yeah. But again, I don't know the legality on it.
Well, I do the same thing in the hospital. If we've got a psych patient that's getting a little riled up, we have officers there and they have body cameras on. And I want them there and I want them to record. So that way, if something goes sideways or there's some complaint about the interaction, I've got objective data to show what transpired.
Last time I used that technique, it was a combative pig slip patient that wanted to fight. And, the police wouldn't engage and help, but they were at least willing to stand at the back of the ambulance and record the melee. Yeah. So, next one. How do I manage seizures that don't stop after the first dose of midazolam?
I mean, my assumption would be this is a tonic-clonic generalized seizure.
Yeah. Or is it obstetrics related? Is it proteinuria?
So I guess let's look at this from an epileptic standpoint, and kind of toss the OB aside. We know magnesium is going to be the.
And we're talking probably about status epilepticus.
Yeah, we're talking about status here if they're non-responsive to the first dose of midazolam, and so how do I manage seizures that don't stop after the first dose of midazolam. I'm giving the author of this the benefit of the doubt. They're already managing their airway and breathing for this patient, right? But if that wasn't implied, then that should be the thing that we should be breathing for this patient, or certainly at least oxygenating this patient.
H's and T's don't only apply to cardiac arrest either.
Definitely a consideration is, can we identify causation? But another dose of midaz or whatever, you probably use anti-epileptic drugs in the hospital.
In the hospital, yeah.
Yeah. We don't generally have the luxury out of hospital.
Correct.
There's been some discussion, so low on the hospital side of things for refractory seizures is the use of ketamine, and we've had some discussion internally about putting it in expressly for this case where they failed a couple of doses. There's some new literature. Do you remember, was that was specific to pediatric, was the stuff we reviewed 2 meetings ago, right? Was it
Sure.
expressly? Anyway.
I mean, it's in my. I'm pulling up my personal notes for when I deal with this. Benzodiazepines after 5 minutes, anti-epileptic medications, exclude hypoglycemia. I can treat hyponatremia.
Sure.
Make sure it's not pyrogenic.
Yep. If we're continuing to seize, we're going to prepare for intubation, and we're going to give. And I've had calls where this has happened, and I'll give verbal orders over the phone to give ketamine.
Ketamine, yeah.
But I'd also at the same time, you're going to be also probably preparing for intubation at that point.
Yeah.
If you're so far down, just to make sure you can oxygenate the patient. But both propofol and ketamine, they do have some they can bring down the noise inside the brain to help calm it down a little bit.
For sure.
And then more benzos.
Yeah,
Once you have an airway established, benzos.
Yeah.
Correct. Although we don't have that written for quite yet. I mean, we can tease that and make sure that people are aware that ketamine can be an adjunctive treatment in this case. And I believe we were talking about dissociative level dosing with this of 1+ milligram per kilogram for the treatment of these seizures.
Which the added benefit, if you don't have IV access, you can also give it IM.
Or intranasally.
Yeah.
So, but airway, and then benzos. Consider other things. Right now has to be in our world. I know there's systems out there that already have had the ketamine in their failed seizure algorithm, if you will.
Yeah, but we've said this before too, that protocol is just your baseline. The things that we've said that you can do without calling us. And there's some carve-outs in there for things you want to call us for, but if it's giving, I'm out of racemic epi and I only have regular epinephrine, can I give that? Yeah. I want to give ketamine for a seizing patient that I've used up all my benzodiazepines. If you're giving us reasonable requests, online med control is going to say yes, and then ask how far out are you and what else do you need when you arrive.
Yeah. What do I do if I suspect sepsis, but the patient looks stable?
Suspect sepsis?
Suspect sepsis, but the patient looks stable.
I'd run through SIRS criteria. I would get good set of vitals, put my patient on end-tidal.
End-tidal, glucose.
Look at, any of my SIRS criteria met, I would look at the respirations. I would get temperature, end-tidal,
Look for
glucose.
probable cause.
Look for probable cause. See, did they recently have a surgery? What does the incision site look like? Maybe.
Are they doing lactics in the field at this department? They could do a lactic. I don't know.
I don't know. I do agree with you. Look at the body, do a good assessment, and see what recently has happened. Is this maybe headed down a pneumonia case, or is it post-op surgery that's at home? You can look at the incision, see if it's inflamed, see if their skin's hot.
They have a history of urinary tract infections. They always act like this.
Do they have a Foley catheter? Look at the bag.
Yeah,
I had
What's their urine look like if they do have one?
We were busy, and I was in the emergency department, and a crew came in. We were gonna have them hold the wall, and I go, "What do you think's going on?" I think they're septic. I'm like, "Why do you think that?" "Oh, they feel warm." I'm like, "Fantastic." I go up, I touch the patient. I'm like, "Yep, I agree. They're septic. They're acting weird. We need a room for this patient."
Yeah.
It's just a quick conversation. The charge nurse, I know we're gonna put this patient on the wall. We just need a room. They're septic. Okay, here's your room. You're gonna take our crash room, right? I think that's worth talking about. Well, we probably haven't talked about it from a ER operation standpoint, and most, whether it's the ER or the ICU, in our critical care areas, we're always going to reserve what we call a crash bed, meaning that we always want to have one room available. We don't plan for staffing to staff that room, because if we're using that room, it's because we urgently need the room. Sure. That's the STEMI room. That's the stroke room. It's the sepsis room. It's the cardiac arrest room, right? It's because we don't want to be. That's the worst thing. We got a full ER, and I'm working a cardiac arrest in the middle of
the hallway,
corner, any other place to put the patient.
So let me forward think this real quick, though, just as an off subject. We have just approved ANSEF in our box for open fractures within our system. How far off are we for getting this maybe for first-round sepsis dosing?
ANSEF's a terrible choice for sepsis.
Okay, so that's the reason
for sepsis.
It's not ceftriaxone.
So all the literature for open fractures, we're worried about skin and dirt and those types of bacteria getting into the wound. And all we need for that is ANSEF, which is a first-generation cephalosporin, as opposed to jumping all the way to a third-generation cephalosporin. And to be good stewards of antibiotics, we want to go with the lowest, least strong, if you will, type of antibiotic to cover that. And even in surgery, people are going to surgery, because we're opening up the body, we're exposing the outside elements inside, they're getting ANSEF just as a prophylactic antibiotic. And that's all it's for.
And for the ACS too, like that's one.
And
if we're talking, yes. I know you're talking specific to antibiotics, but
surgical
something's listening to this could apply actually across whatever state you're in. A lot of the procedures, if you're a trauma center, you want to be able to give that. If you have a type of open fracture, you want to give the antibiotic within the first hour for that open fracture for the college.
It's not even like going through a washout. It's how quickly can you get antibiotics to the patient that lowers the risk of having osteomyelitis, so having a bone infection, and having a bone infection is really bad, and getting rid of a bone infection is tough. It's very, very hard. It's weeks of antibiotics.
Yeah, so I got you. Does that open a door, you think, in the future to be given? That will.
I have an opinion on this.
I mean, let's say that we were able to do our first blood cultures. And
I think it complicates it, but go ahead.
It does. I mean, even if we're looking at sepsis, even in the hospital, we're not 100% great at it. We're still striving to be better at it. Sepsis, looking longitudinally, has gone from a 3-hour time frame, so we don't have those limited time frames we're looking at. ACS, looking for open fractures, we're looking for those antibiotics within the first hour. So that's why it's getting pushed more towards pre-hospital space. Because even we're bad at starting in the first hour in the ER.
Yep.
And so because we're bad at it, we're just going to push it on you guys. But it also helps the patient, right? Because when they arrive in there, we're going to do our assessment. That's, say, 5 to 15 minutes, depending upon how sick the patient is. Package the patient up. We go to CAT scan. We scan them. We bring them back from CAT scan. We review the images.
You're doing labs. We're doing everything else.
We're doing labs. We're controlling pain. We're starting fluids. We're doing IVs. And that hour very quickly goes away.
So to your point, not to interrupt you, like on the flip side of that, for sepsis pre-hospitally, we're looking at all those things I mentioned, and then maybe the possible derivative of like what is causing this infection, and I almost look like for us it would be like fluid replacement, right?
That's
that infection happens,
resuscitate before you medicate.
Correct. Yeah. So we're almost trying to push for the fluid resuscitation prior to your arrival, acknowledging, hey, this patient I believe is septic. We're going to decrease our mortality rate. We've done some fluid replenishment. I have a stable blood pressure, and then kind of for lack of a better word, pass it off to you, and then you can go with more of a specific antibiotic.
So right now we're looking at the first 3 hours when it comes to sepsis. There's some talk about moving that sepsis bundle and getting antibiotics within the first hour, but that time doesn't start until we identify the infection.
Gotcha.
So sepsis is SIRS, so we have to have 2 SIRS criteria plus an identified source of infection. Now, surgical site infection, it's red. There's purulent drainage from it. Yeah, sure. I've got my source of infection. They're tachycardic. They're tachypneic. Great. They meet sepsis criteria. You can say this smells like a urinary tract infection, but I can't prove that this is a urinary tract infection. This sounds like, and even last night I got fooled. I worked. I thought for sure this guy came in. He felt bad. He's not on oxygen. He has some COPD. He got some breathing treatments. He's been sick for the past week, and now he comes in wanting more oxygen. Lungs sound like crap. I thought for sure, and I think he had a fever. I thought for sure, man, this is going to be pneumonia.
Yeah.
I was wrong.
Yeah.
He had a COPD exacerbation triggered by a viral infection.
And an infection.
Yeah, and so I
Okay.
didn't have, for him, meet SIRS criteria. I had no identifiable
Source.
of
Yeah.
infection. He didn't need antibiotics.
Sure.
He was a viral infection that
Yeah.
triggered this. And he just went home. He doesn't need antibiotics. So, I mean, docs get fooled, you guys can get fooled. And what we need to, and part of the reason why that source infection is important, because then we need to choose which antibiotics go with that. If it's a urinary tract infection, go-to is probably going to be ceftriaxone. If it's a lung infection, pneumonia, one of the antibiotics they're going to get is going to probably be ceftriaxone. But if we're talking about, has this patient been admitted to the hospital in the last 90 days, is this a hospital-associated infection, they're not going to get ceftriaxone, they're going to more likely get vancomycin and zosyn. Or maybe if we have blood cultures that they've grown up before, am I going to choose something else? I've had a bunch of broad-spectrum resistant UTIs lately that I'm ordering meropenem on. So ceftriaxone, whatever bug that is like, I don't care whatever bug juice you gave me, it ain't going to work on me. I need the stronger stuff.
Right, yeah.
Sepsis isn't an easy thing, but again, yes, how you want to treat your sepsis patients?
Fluid.
Give them fluids.
Yeah.
And I think he just bolstered my statement of I think it adds complication. Well, but I think it adds complication.
Yeah. And you and I
I'm
have
not
talked
saying
about the
I'm
importance
not
of
saying
like a
we're not
shock
going to get
index.
there, but then we're all already.
But I also, to your point, I need blood cultures before you do that.
It's
right?
more complex versus just I'm going to give him an antibiotic.
Correct.
Yeah.
Where some people are like, I'm just going to give him an antibiotic.
It's not one size fits all.
Ultimately can and would fix the problem, but then if I don't have blood cultures or a source culture that I can then be able to de-escalate from those meropenem, that I can maybe escalate down to nitrofurantoin, I'm going to have this patient on meropenem for some reason. And now I'm going to start breeding bacteria that are going to be resistant to
that,
meropenem.
right.
Yeah.
And now I got to go to my other penoms and I got to really
It just
talk.
overcomplicates it even
Yes.
more. Yes.
Yeah. And we talked about this in transfusion medicine. There's a whole subsection of medicine that talks about antibiotic stewardship. And it's an ongoing conversation. We're using a lot of very strong antibiotics. I even caution when, we'll just give them ceftriaxone. I want ceftriaxone to work for me when I get sick. I don't want to really dilute this out. We've been expanding all of those meropenems down to my level to that way. Before it was, let's say 20 years ago, you can't order that. You have to have a special degree and all this to order that. Now I can at least order first 24 hours. I'm even having conversations where I'm talking to pharmacy saying, I need you to order this specific antibiotic because I'm looking back at ID's last notes and I'm looked at the cultures and like, it's this med that I don't even have access to order. Pharmacy, you have to order this for me to give this to the patient.
Wow.
They're like, yeah, they do need that.
Going back to the resuscitate then medicate kind of.
But we're all resuscitated. That's our jam, right?
That's what emergency medicine, whether in hospital or out of hospital, that should be our first step always. But going back to your point, what do I do if if I suspect sepsis, the patient looks stable? Fluids are generally safe. I mean, I guess that would be my canned answer to that. It's if you don't know, but you have the markers, fluid resuscitate them.
Yeah.
And I think the passing on that report to the emergency room is huge as well, right? So why do so many people die from sepsis? Why does it have such a high mortality and morbidity rate, right? Early recognition.
Yep.
So I think passing that along to the nursing staff, giving a good report, telling the physician as well, I think is also very important. Even though they see, hey, I think the patient, they're septic because of this.
Well,
that's important to you, right?
you can have people the broad definition of a sepsis patient and they are flu positive.
Yeah.
They don't, but because we've carved out for viral infections, it doesn't. COVID's the same way. They meet sepsis criteria, but their infection's a viral infection, so they're not really septic. Yeah. But they check all those flags.
Sure.
Understand for SIRS, it's kind of important that we're talking about an elevated heart rate of 90 or above. If they're not tachycardic, it's not above 100. So 92, and if you're documenting or you have a heart rate above 90 and they're breathing more than let's say 25 times a minute, because I know that's high enough, there's already triggered SIRS. Mm-hmm. So it's SIRS is actually not a very high bar to clear.
Not a clear, right?
And that's why we have to add gestalt of I've identified an infection or I have a high likelihood that there's an infection going on before we trigger sepsis, because then what we're going to start doing is we're giving bug juice and these antibiotics to everybody and cause
Bug
problems.
juice.
Bug juice.
I
It's
love
called bug juice.
Bug
Right,
juice.
right. Click save. I'm going to use
My
that.
sniffer is telling me.
Yeah.
No, I'm just kidding. I got a hot UTI
T-shirt
right
That's
now.
right.
dog.
Yeah.